Very good evening to all of you. Allowed me to say that I was not really properly briefed about this meeting, and so I had to put up some slides at the last minute about innovation. And we do have a lot of innovation, don't we? This is perhaps one of the latest ones. But, you know, I come from Italy. Italy has a very, very long story. And so we were not very surprised because we had, many years ago, this innovation. Probably you don't know, but this is Mr. Berlusconi that we elected and re-elected. And he is very famous for politics, but also for his interest in women. And already, if you go to internet, the two innovative presidents have been put it together. But we are in India. And I heard that also there is another innovation here. Whether it's good or bad, that is for you to judge. But there are innovations coming every day. And we heard that innovation means creativity. And I was briefed to talk about advances in beta blocker in heart failure. And that, believe me, was a very creative thought. And I'd like to start with the history of heart failure, because when I was at the medical school, I was taught, and perhaps how many of you is a cardiologist, or how many of you treats heart failure? Can you raise your hand? Okay, so, well, probably you also knew about the back and forward theories, and we had just digitalis diuretics, and we were suggesting the patients to rest in bed. Then in the 80s, cardiologists started to talk about inotropism, the force of contraction of the heart. And then we had this concept of a pre and after load. And therefore, the positive inotropic drugs and the vasodilators were introduced into cardiology. And that was an extremely logical idea, because you see there is a very clear relationship between contraction, here expressed in terms of, it's quite difficult because there is the chair, is in terms of ejection fraction and prognosis or mortality, if you prefer. The lower is the contraction, the higher is the lower is the survival. So if I can increase the ejection fraction, logically I should increase the survival. And this is the survival not of the patients who receive the positive inotropic drugs, but is the survival of the trials with positive inotropic drugs. All of them has been stopped prematurely because they were killing patients instead of saving them. Completely different results from what was extremely logic at that time. And then, in the end of the 80s, we started to prize the so-called compensatory theory. And we started to think that the neuroendocrine activation that occurs in heart failure was compensatory, was there to help the patients with heart failure. Well, there were problems in this theory, because number one, why should nature provide the human beings with a compensatory mechanism against a disease? Nature is not so generous, doesn't care about our disease. It cares only to important adaptation which are relevant for the survival of the species, and not only of the human beings. And not only that, but it was difficult to understand the real neuroendocrine response to heart failure, because all the patients coming into the hospital with heart failure, they were treated at the time with vasodilators, diuretics, and inotropes. And all of these drugs cause a neuroendocrine response. That is the very reason why 40 years ago I came to your country. And actually I came to this part of India in Punjab, and more specifically at the PGI Institute, where, by the way, I saw the best medicine in my life. Fantastic institute. And the reason why we went there is because it was possible to meet some, not many, patients who came in with really severe heart failure and they never saw a doctor in their life. And they were completely untreated. And we look at the hemodynamic of the patients, and obviously there was a reduction in the cardiac output, in the pumping function of the heart. There was a reduction of the renal blood flow and the GFR. There was an accumulation of sodium and water. Patients were in edema. The only thing that was unchanged was the blood pressure, which is down here. And then we look at the neuroendocrine activation in these untreated patients. And there was an increase of norepinephrine, of prolactin, of aldosterone, and at that time we were measuring the anti-natriuretic peptide. And then we compare this neuroendocrine response with the neuroendocrine response of untreated patients with the myocardial infarction in green, or with volunteers like myself going into an exercise, or given into volunteers, not patients, an injection of nitroprusside to drop the blood pressure. And the results are in front of your eyes. Exactly the same type of response. That means that the neuroendocrine activation is not specific at all for the patient with heart failure. It is just a stereotype response which is evoked when the blood pressure is threatened and started to decline. It is essential, and that is why nature has provided the mammalians with this response. It is essential for the mammalians to hunt and to reduce the bleeding when they are hunting and the blood pressure drops down. Therefore, it is very useful for the survival of the species. And it is very useful for these mammalians. But it is also useful in human beings, but in short terms. And that neuroendocrine response, you develop it any time that you have a stress response. When you are just braking because you are going to kill somebody driving your car. If I take a blood samples, you will be in acute heart failure. The problem, however, is that in heart failure, the muscles of the heart are failing. And the blood pressure is threatening chronically for years. And this constant neuroendocrine activation becomes very dangerous. This observation is a fundamental observation, not because we made it, but because it gave rise to a complete change in treating the patients with heart failure. And we started to use in 1987 the ACE inhibitors, and 2 years after the beta blockers, which was totally, completely illogical. I was in England during my PhD, and if you would have given a beta blocker to a patient with heart failure, you could be taken to the court. They were absolutely contraindicated. Today are the most important drugs that we are using in heart failure. And that was really a dramatic change because we realized that the neuroendocrine response was dangerous. Heart failure, therefore, became a neuroendocrine disease, and at that time there were a lot of evidence-based medicine invading cardiology, and so we did look at prognosis versus symptoms. And indeed, the beta blockers are important for the prognosis. Actually, in the first months, they are really not very nice in terms of symptoms. Actually, the patient is feeling worse. But then we'll have a lot of benefit. So look at the involvement from vasodilators to ACE inhibitors, from positive inotropic agent to negative inotropic agent, which in heart failure very strangely, and I will tell you why, are becoming positive inotropics. From rest in bed, in my hospital, we have a gymnasium because the heart failure center is sending the patients to some training. Completely different revolution. And each of this creativity, each of this innovation did help in reducing the mortality of the patients with heart failure. The ACE inhibitors did, the beta blockers did even more, and the anti-aldosterone drugs even more. Beta blockers today are suggested by the guidelines as the first drugs to be used together with ACE inhibitor because they reduce the enlargement of the ventricle, that we call it remodeling, and because they reduce sudden cardiac death. These are the newly developed guidelines for the European Society of Cardiology, and as you can see, they are starting with the beta blockers and ACE inhibitors. And then you can see here there are 3 other innovations that we are using in heart failure. Some of you as a cardiologist will know about the ARNI. It's a new class of drugs which is quite helpful for heart failure. Some of you will know about ivabradine, which is a specific drug that is reducing the heart rate without having any other hemodynamic effect. And many of you will know about CRT and the possibility to resynchronize the ventricle. But just to stay for the beta blockers, the reason why we are using them is number one, because they are reducing heart rate, because they are reducing sudden death, because they are reducing the negative effect of chronically increased catecholamines on the myocardium, because they improve contractility, and by this way they reduce remodeling. I don't want to spend a lot of time. We have really evidence that the beta blockers can reduce sudden cardiac death. We do evidence of what the catecholamines are doing on the human myocyte. This is a human isolated myocyte. Look what is happening if I'm giving some catecholamines to it. It will shrimp. It will be not able to contract any longer. And rats which are overexpressing the beta-2 receptors, look what is happening to the ventricle, and they will die much quicker. But the most important thing is that beta blockers in heart failure are causing an increase of contraction, which is, for us, reduction of remodeling. And you can see that the increase of the ejection fraction is quite substantial. And then you go back to that early slides. If I can improve contractility with the beta blockers, I can improve survival. And the answer and the question is why I cannot do it with positive inotropic agent, which is logic, and I can do it with negative inotropic agent, which is not logic. Well, because beta blockers in heart failure are the ideal inotropes. The positive inotropic agents failed because the increase in contractility is linked with an increase in oxygen consumption, which is limited in heart failure. But for the beta blocker, it's the opposite, because they reduce the oxygen consumption, because they reduce heart rate. And also, it is very important to point out, this slide is really a key slide if you want to understand the good effect of beta blockers. Because here, this is a human papillary muscle strips, which has been isolated from patients undergoing transplantation. And if you take the normal human papillary muscle, if you increase the heart rate here, you can see that you increase the force of contraction very clearly. But look what's happening in a papillary muscle from the area which is failing. The curve is not the same, it's the opposite. The more you increase heart rate, the more you decrease contraction. And if you are able to bring the heart rate from here to here, you will reduce the oxygen consumption, because heart rate is the major determinant of oxygen consumption, but at the same time, you will increase contractility. That is why beta blockers in heart failure are positive inotropic agent. We should use the beta blocker mainly to all the patients with heart failure. And no question that they should be used. The problem for us, cardiologists, is that we are using correctly in 92% of the patients. This is a registry from European cardiologists that, by the way, I conducted. But look, we are using at the right dose only in 17% of our patients. In other words, we are underusing it. We are underdosing the beta blockers. And that is because it is not easy to use, at least for the first months. And there are several possible contraindications from COPD, bradycardia, sense of fatigue, symptomatic hypotension. And really you have to convince the patient that drugs which will make him feeling slightly weaker at the beginning will save his life later on. And the big problem is whether we should think about the target dose or the target effect. And I would suggest you to use the beta blockers for the target effect, because that is more individualized to the patient, and you should use at the dose which is enough to bring the heart rate to 60 beats per minute. The guidelines do not suggest which beta blockers we should use. The more utilized are bisoprolol, metoprolol, and carvedilol. And these are the main 3 studies, all showing a very good improvement in survival. But there is something new, and that is an innovation. And the name of this innovation is nebivolol, which is a new beta blocker, which not only is beta-1 selective, but also it is acting on the endothelium of the patients and allows more release of nitric oxide, which is important because it also dilates the arteries and therefore reduces the afterload and make these drugs to be more acceptable for the patients, at least at the beginning. Senior has been, nebivolol has been studied in a rather important study called the Senior Trial. I was in the executive committee of the trial, and what is special of this trial is that we target the real population with heart failure, those patients which are 70 years old or even more. The results were clear-cut. There was a statistically significant reduction in the hospitalization and the cardiovascular mortality of these elderly patients. There were also smaller studies looking at the effect of nebivolol in comparison with metoprolol and carvedilol. To make a long story short, nebivolol group experienced less cardiovascular events during the 12 months of the study, and that was mainly due to less rehospitalization of the patients. And you can see here the grading. Nebivolol was the best, followed by carvedilol, followed by metoprolol. And these results were statistically significant. So nebivolol maybe that is the ideal beta blockers for the elderly patients, and it is completely free of any side effects and produce the best outcome when compared with the operators. The superiority of nebivolol versus the other beta blockers is likely to be done to its innovative effect on the endothelium, and in my opinion, nebivolol should be really tested in patients with a particular subset of heart failure. And that may be new for you who are not cardiologists, because today we are also talking about patients with heart failure with preserved ejection fraction. And I believe that is important to consider that the underlying physiopathology of a patient with heart failure and reduced contractility, let's put in this way, and the patient in heart failure with normal contractility, the pathophysiology is completely different, and we should know it. The patient with heart failure and reduced ejection fraction, in these patients, the syndrome of heart failure originates from the heart and is driven by a myocardial cell loss and fibrosis. These are the results of mainly a myocardial infarction or an endocarditis, which leaves less myocyte to contract or more fibrosis. Then this problem, starting in the heart, goes to the periphery, and it causes the neuroendocrine response because the blood pressure is threatened. Different is the situation in heart failure with preserved ejection fraction, which is a systemic syndrome which is driven by accumulated risk factors and comorbidities in rather vulnerable subjects, mainly aged patients, with important cardiovascular component. In other words, the problem in this particular typology of heart failure starts from the periphery and then gets to the heart. And you can see here in heart failure with preserved ejection fractions are all these comorbidities like obesity, and we are going to hear in a minute about the importance of obesity, hypertension, diabetes, COPD, iron deficiency. Put all of this together, it causes probably generation of oxygen-free radicals, which then are causing a damage to the heart. But in heart failure due to reduced ejection fraction is the opposite. The damage starts from the heart because of the infarct or of the endocarditis and then gets to the periphery. Also, the phenotype of these two different pathology is completely the opposite, because in heart failure with reduced ejection fraction, you can see that after the index event, let's say a myocardial infarction, what is happening to the ventricle, it dilates and continues to dilate, and more it dilates, more remodels, less is the prognosis. In the preserved ejection fraction, you can see that the ventricle shrinks, becomes hypertrophic, and the cavity becomes smaller and smaller. And it is also interesting that if you take the so-called cardiovascular continuum, in the heart failure with reduced ejection fraction, first you have all these risk factors causing myocardial ischemia, myocardial infarction, and eventually heart failure. In heart failure with preserved ejection fraction, it is all these risk factors in age population which jump directly to heart failure, but with a completely different phenotype. Large ventricle here, massive hypertrophy here, or if you prefer, and the risk factors, the classical one, you can read them here, but aging is the most important thing. And in fact, the heart failure with the preserved systolic fraction is particularly prevalent in people aged more than 80 years. The problem here is that we do not know how to treat this condition, because all the drugs which has been treated up to now, except nebivolol, has not produced any good results. The only positive results has been provided by exercise. And that is very interesting, you know. And if you randomize these patients, if you send them to constant exercise training, you will see that you will improve their peak oxygen consumption and the maximum workload. We do not know about the prognosis yet, but we will find out. And so I like to conclude, because it's late and there is another speaker, probably more interesting than me, coming after. But in heart failure with preserved ejection fraction, we need to understand the situation more. We need to prevent the situation. We need to find a specific therapy in order to get the same good results that we are offering to our patients with heart failure and reduce ejection fraction. And I like to put to you tonight that nebivolol theoretically could be very useful and, in my opinion, should be tested. And I hope that it could be tested in your country. Thank you very much for your attention.